Bladder tumor, apart from the kidney, the ureter, the bladder, all of these are lined by which type of epithelium? Which type of epithelium? Transitional epithelium. Transition means something between the squamous epithelium and columnar epithelium. So this whole of this urinary tract is lined by transitional epithelium. In other words, we call it urothelium. So when we call bladder tumor or bladder carcinoma, a better terminology is that we will call it urothelial tumor or urothelial carcinoma. So this is one of the most, though it is not so important for you, it is important for neurosurgeons and postgraduate surgeons. But you have, this is very common problem in everyone's life, everyday life. So urothelial tumor or bladder tumor. So do you know what's the presentation? Do you know what's the presentation? It is generally found in the elderly patient, in your any elderly parents, your elderly neighbors. What will be the common presentation by which you can suspect or raise your doubts? What is the common presentation of urothelial tumor or bladder tumor? Can anyone know? Can anyone raise his or her hand? What is the common presentation of bladder tumors? Ball? Any symptoms? It must be related with urine or urination. So what should be, can you tell me what is the normal common symptoms of urinary calculus or urinary stone? Painful micturition, pain during micturition, if it is urinary stone, and maybe some bleeding. So remember that in case of urothelial tumor or bladder tumor, the main common symptoms is painless hematuria, not painful, painless hematuria. There might be some pain if it is very well advanced. So this is painless hematuria. Even you may find blood clot in your urine. So this is the common presentation. But remember also that whenever there is any hematuria, you must exclude first any kidney stone or possibility of any urinary tract infection. Most common urinary symptoms is urinary tract infection. In everybody, both males, females, urinary tract infection. So it is ruled out. First say to yourself, no, this is not urinary tract infection by examination of urine. Then comes stone, which can be well seen in a simple X-ray, or stone is always painful. If these two are not a possibility, then you suspect bladder tumor. Understand my point? So bladder tumor is painless hematuria. So whenever there are some tumor, there is always the term WHO comes in, World Health Organization. What is its duty? To make an uniformity of tumor nomenclature and diagnosis of tumor between all countries. অনেক countries আছে, Asian countries আছে, European countries আছে, America আছে. There are so many people like us, so many students like you. So they make uniformity. So everybody learns the same diagnosis. Everybody use the same nomenclature. That is the rationality of using World Health Organization's nomenclature. We have also some category, some rules to diagnose any tumor. We have to read the WHO blue books so that we, uh, we don't use any abnormal terminology, etc. So this is the, so what are they? Urothelial papilloma. Whenever there is oma, you understand that it is a benign tumor. Oma. Urothelial papilloma. Next is inverted papilloma. Inverted papilloma means, suppose this is the surface. So when the tumor is outside, within the bladder lumen, it is papilloma. While it is inside, growth is inside. Both are benign. This is inverted papilloma. Inverted papilloma. This term you will get in neck region also. When you will read the area of the head and neck, sorry, the nose region also. There is a term called inverted papilloma. So it is a very bad term. Though benign, it is very difficult to curate it out, to operate it out, because it is gone inside. That is the problem. So what is this? Papillary urothelial neoplasm of low malignant potential. So something between papilloma and carcinoma. If it is more atypical, more pleomorphic than a papilloma, but less than that of a carcinoma, we call it PUNLMP. This is not so important for you, but it is a headache for us. We have to diagnose it. So these are the main thing. Carcinoma, 2 counts, low grade carcinoma and non-invasive high grade carcinoma. You know, carcinoma may be non-invasive, may be invasive. So this is non-invasive carcinoma, this is carcinoma in Situ or in Situ, this is invasive urothelial carcinoma. So what is the difference between, so far surgeons are concerned, what is the difference between non-invasive and invasive? In non-invasive, you can just remove the tumor, bulk of the tumor from bladder. In invasive carcinoma, you have to remove the whole bladder. You have to make an artificial bladder. That is the main problem. And that difficulty of diagnosing the case lies on us. If we make mistakes, the whole bladder will be removed. So, this just see the picture. These pictures are just like papillae. Papillae lined by normal urothelium, not so thick, no atypia, no pleomorphism, normal papillae. But on endoscopy, there is a growth. So, our diagnosis or your diagnosis will be urothelial papilloma. These are normal, slightly thickened. Mucosa is slightly thickened, but these are normal. Same thing, the same schematic diagram I have drawn, the cripple-like, the papillae-like, the finger-like projections from the bladder mucosa. These are urothelial papilloma. See, what is this? This is the mucosa of the bladder wall. Mucosa of the bladder wall. There is nothing outside, but the tumor is inside. Here is the tumor. These are papillae. So, what does it mean? This is a benign tumor consisting of papillae, consisting of finger-like projections, but they have gone inside. It is a difficulty for surgeons who will operate because they have to curate it out, and it is very difficult to curate all the portions. Same inverted papilloma in hyperview. This is the bladder mucosa wall. See how nice it is. The papillary structure, the finger-like structure. But nothing above the mucosa of the gallbladder. These are all inside the mucosa of the gallbladder. See what is written. Focal degenerative cytological atypia without associated mitotic activity. Focal atypia without mitotic activity. Mitotic activity means cancer, carcinoma. So, papillary urothelial neoplasm of low malignant potential. PUNLMP, I have told you, this is not benign looking, this is in between benign looking papilloma and carcinoma, in between. See, same thing, same papillary projections, but they are fused, slightly atypical. Same papilloma. So, in between, we call it PUNLMP. This is not a problem for you, this is problem for us. It's very difficult to diagnose. PUNLMP. Now comes the carcinoma, where the cells are more pleomorphic, more hyperchromatic, more MC ratio, etc., etc. What is written? Mild atypia. Because it is low grade. That's why mild atypia and architectural disorder. Photomicrograph, fused papillae with mild nuclear enlargement. See, so thick. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 layers of epithelium. Normally 3, 4 layers. So it is cells are atypical. There is mitotic figure. So this is low grade but non-invasive carcinoma. Papillae are lined by urothelium with minor cytologic and architectural disorder. Papillae are lined by thickened urothelium with mild cytologic atypia and minimal architectural disorder. Same thing, low power. Same thing, high power. Same low grade non-invasive papillary urothelial carcinoma. These are papillae, but slightly more atypia, more hyperchromasia. See the high grade one. The individual cells are more pleomorphic, more hyperchromatic. So it is, we call it high grade. Papillae cannot be distinguished, they are fused together. Note the disorder, architecture and nuclear pleomorphism with nuclear hyperchromasia. Non-invasive papillary urothelial carcinoma, high grade. Pleomorphic urothelial cells. So atypia and pleomorphism are in the surface only. There is no involvement of the, no ingression inside the substance, inside the subepithelial connective tissue. Urothelial carcinoma in situ or in situ. So this layer only pleomorphic, no invasion. These are all normal. See, this is lining epithelium. This is only abnormal. No cancer cell has gone inside. This is called urothelial carcinoma in situ. What are these? What are these? These are bladder wall muscle tissue, bladder muscles. So if the cancer cells has gone inside the muscle, we call it invasive. If it does not invade inside the muscle, it is not inside the muscle, we call it non-invasive. In invasive, we have to remove the whole of the bladder. In non-invasive, we don't have to remove the bladder. So these are the cancer cells. Here, in between muscles, there are cancer cells. আমাকে বল এবারে যে ব্লাডার ক্যান্সার তোরা অনেক ক্যান্সারের you know what are the etiology. Bladder cancer, tell me 1, 2 etiology. বল তুই বল bladder cancer 1, 2 etiology. Cause of bladder cancer. Anyone? তো লেখাই আছে, দেখে বলে দে। Stand up. দাঁড়া না, কি লেখা আছে? Smoking, very important. Radiation, very important. Arsenic, cystosoma, এই নামটা শুনেছিস? Have you heard the name? Huh? Have you heard the name? This is one parasite found in our country. Not in our country, probably in Africa or like this. So even a parasite can cause bladder carcinoma. Remember this. Huh? So radiation is important, smoking is important, schistosomiasis, Lynch syndrome is a genetic disorder. So these are the etiological factors. So remember, smoking is everywhere. It's in ulcerative colitis, it's in lung carcinoma, it's in bladder carcinoma, it's in colonic carcinoma, everywhere. So shun, avoid smoking. Sit down. So nowadays, everything, all cancers, or almost all cancers, they are related with some or more genetic abnormalities. It is not always possible to remember all the genetic abnormalities. Just you write down some mutations are some pathways are important for genetic aberrations are important for causation of cancers.